much for that introduction, and really appreciate the invite to present. So it's such an honor. Pain BC does such great work, has such a great reputation. So really appreciate the opportunity to be here. So let's get right into it. So yeah, both of us are postdoc researchers. I'm based out of McGill, Sabrina based out of Germany, and we've got this kind of unique collaboration combining our eclectic backgrounds, and we've been doing some work over the last year together, and this is kind of this presentation is what kind of has been coming out of that. So really brief outline. So we're going to go over some historical pain theories from Descartes up to the biopsychosocial model of pain. We're going to outline some biopsychosocial model limitations and challenges. And we're going to introduce a novel way to view pain. So something called the enactive approach to pain. And we're going to touch on a little bit of clinical application. So just want to flag early on, this is still work in progress. So this is the first time Sabrina and I have actually kind of formally presented some of this material together. So bear with us. This work is still fluid. So most of this presentation is based on these two philosophy papers. So they're published in philosophy journals. We use really kind of field-specific philosophical terminology based in certain types of traditions. So some of you, if you take a look at these papers, some of the wording and the language might seem quite foreign. So what we're going to try to do in this presentation is hit on some of the key points and some of the key messages that came out of these two papers. So you might be wondering why philosophy pain theories. I'm stoked to see all the people that have showed up to listen to this, because this is stuff that I think oftentimes people avoid, and I know I certainly have in the past. And but over the years, realize how important philosophy is, how important our pain theories are. In the latest book, Cause Health book, Anjum et al., they really highlight this nicely. So I really like this quote. They say that no practice takes place in a philosophical vacuum, and medicine is no exception. Health sciences and healthcare practice are enabled, shaped, and restricted by tacit philosophical assumptions of which practitioners should be aware. So this definitely applies to pain. So everybody has a working kind of belief or a working kind of understanding of pain, whether we realize it or not, and whether we kind of label these assumptions or beliefs or not. So we all have them. And what's important is these types of understandings, these assumptions, they do shape the way that we assess pain, the way that we explain pain, and the way that we treat pain. So I know a lot of you joining today are clinicians, so you work with people experiencing pain, and so you'll be very familiar with this. So people often want to know why they hurt, why they're continuing to have pain. But we're faced with this huge clinical challenge in that often pain is kind of so-called non-specific, so meaning that there's no cancer, there's no infection, there's no fracture, there's no autoimmune condition or some sort of clear underlying pathology. So we do focus on MSK conditions, back pain in those two papers, because it is now known as the leading cause of disability worldwide. Yet most back pain, there is no specific cause. There's no clear thing, anatomical thing that we can pinpoint. So this presents that huge clinical challenge. Patients want to know why they hurt, yet it's very difficult to actually navigate that. So this is often what it looks like. So the patient is kind of the elephant in the middle. They're seeing a variety of different healthcare practitioners. Each practitioner takes kind of often a different approach. Oftentimes people are zooming in on certain parts of the patient and giving kind of very specific explanations as to why they're continuing to have pain. And this is often very frustrating and confusing for patients as they get different messages. And we know from some of especially the more recent kind of qualitative literature, we get some insight into the patient perspective, especially around persistent muscle and joint pain. So patients continue to say that they're not listened to, they're dismissed, the pain isn't real, it's all in their head, they're not taken seriously, and the life impact of pain isn't fully explored. And paradoxically, sometimes when people are given those kind of specific diagnoses for a non-specific condition, often like most types of back pain, this can be validating in a sense, but also often we know from the literature that practitioners are relaying the message that the body's just a broken machine, that it needs to be fixed. Sometimes relaying the message that pain is permanent and there's just nothing that you can do. And me over the years, as navigating the healthcare system personally, I resonate with a lot of this, and yeah, challenging and extremely frustrating. So with that background out of the way, we're going to now start going into some historical pain theories. So starting with Descartes, famous philosopher of the 17th century. So he had kind of a very kind of linear and mechanical view of pain. So most of you will be familiar with the picture on the bottom left there. So you have the fire stimulating the peripheral tissues. A signal goes up, straight up, linear path directly up to the brain, and the person experiences pain. So that was that kind of linear mechanical view of Descartes. And if things weren't, just to make things a bit messy, he also introduced this idea of dualism, the mind and body are separate substances, and we're still grappling with the repercussions of that today. And although Descartes is a philosopher from the 17th century, we're still, when we look at what's going on in the media, sometimes what people are told in pain clinics, we're still very much kind of stuck in that era of Descartes. So I don't mean to pick on Dr. Oz, but I think this is a good example. So in this widely watched video from his TV show, he describes how the spine is like hockey pucks divided by jelly donuts. And he describes to this individual from the audience that when we sit for too long, the discs get crushed, the donuts get crushed, and what looks like blood starts spurting out. So the jelly from the donuts, and really still a very kind of linear mechanical view of pain. The discs get crushed, and then you experience pain. After Descartes, a variety of other theories have been proposed. So specificity theory, intensity theory, pattern theory, other types of similar approaches. And what they all have kind of in common with that kind of early Descartes view is that they're kind of linear and predictable views of pain. So treating the body almost like a machine, so kind of like a clock with different gears that are working together. And if a gear breaks, often the other gears will kind of, they'll stop, but those other gears themselves are not changed. So often with this kind of paradigm, the approach to pain would be, well, let's go try to find that single broken gear, and we're either going to kind of fix it or replace it. So these early pain theories were very kind of tissue and peripheral focus. So kind of like focusing and trying to find that single broken gear. So what are some of the implications of all these early pain theories? Well, often there was kind of a push to go towards these kind of mechanical fixes, yet the outcomes were often not as good as people were expecting. The other huge implication is that if there was no kind of identifiable bodily tissue issue, so there was no kind of broken metaphorical gear to find, people were often essentially told that the pain isn't real, that it's all in their head. People without kind of signs of organic disease were labeled as psychologically disturbed. And really, if we look at kind of contemporary times, this is still happening. And I think this is unacceptable. It's so frustrating for people experiencing persistent pain. So what happened after those early pain theories? So the gate control theory came out in 1965, proposed by Melzack and Wall. Most of you will be familiar with this. Things started to get a bit more complex. So it's not just a simple pathway from the periphery up to the brain. So they said that, well, we got to look at the spinal cord. These danger signals from the tissues, nociception, it can actually get modulated or changed at the spinal cord. They also propose that the brain isn't just this passive organ. It can actually actively have a role as well. So it can have anti-nociceptive effects, or kind of, in other words, kind of dampen those danger signals coming from the periphery. So what are some of the implications of the gate control theory? Well, huge advancement, because it starts to actually explain injury without pain and the variable relationship between injury severity and pain intensity. So I think most of you will be familiar with this. I think of examples of athletes at big events where they can have quite catastrophic injuries, yet report little to no pain. So the gate control theory, to a certain extent, starts to explain some of those scenarios. But what it doesn't really explain is the opposite, so pain without injury. So that's where the neural matrix theory comes into play. So this came out in 90s, refined through the 2000s. So with this, there was kind of a move away from the more kind of periphery, the more kind of a peripheral focus, and then a more focus on the brain and the central nervous system. So I think most of you will be familiar with this image. So the general idea is that pain is produced by this widely distributed neural network in the brain. So what are the kind of implications of this neuromatrix theory? Well, it starts to explain what maybe the gate control theory couldn't fully explain, was the opposite. So where pain is occurring, but without injury. So examples like congenital phantom limb pain. So a person's born without a limb, yet they then experience pain where that limb would typically be. So once again, huge advancement in terms of pain science, but there was also some implications with this. So people started to say, well, yeah, the brain, it really makes sense to really focus in on the brain. Pain is ultimately in the brain. We just need to retrain our brain to get out of pain, or pain is an output of the brain. So once again, a huge advancement, but we also have to consider some of the implications if we get too focused on this kind of brain neurocentric view. So people like Raymond Tallis call this neural mania. Alan Jasanoff calls it the cerebral mystique. So if we just get too excited to look to the brain to kind of explain all these different types of things, there may be repercussions. So I like this quote from Alan Jasanoff. I think it really highlights what I'm trying to get at here. He says that the more that we feel that our brains encapsulate our essence as individuals, and the more we believe our thoughts and actions simply emanate from the bundle of flesh in our heads, the less sensitive we'll be to the role of society and environment around us, and the less that we'll do to nurture our shared culture and resources. So there are kind of clinical implications with this as well. So I know early on, and I know I definitely fell into this trend where we thought that really focusing in on biological explanations, these kind of brain explanations, would be helpful for patients. But now we're seeing evidence, for example, with mental health conditions, where these strong kind of bio and brain-based explanations may actually increase stigma and negative beliefs among a lot of people. And clinicians and patients, if we do take a too kind of narrow, kind of brain-centric view, we may actually overlook established evidence-based interventions. So there's not a lot of pain research actually done in this area, so more kind of in the realm of mental health, but I think that's something that needs to be in our radar. There may be kind of unintended consequences if we get too excited about the brain. That said, don't get me wrong, the brain and physiology are extremely important. These things are necessary. But the issue is that pain research and practice has long been kind of dominated by these very reductionist approaches to pain. So this represents a really strong oversimplification of the complexities of pain. And if we take this kind of way too much of a narrow focus, we may actually miss some relevant knowledge on the generation, maintenance, and treatment of pain. And I think for a lot of you, this will seem, of course, this is the case, but this last point, we do have to bring this up. There's situations where we may actually be ignoring that it's the person as a whole in a certain context that's experiencing pain. So what we've largely done in the past, clinical research, like basic sciences, clinical practice, we've illuminated a lot of these kind of physiological mechanisms, often using kind of more quantitative approaches. Yet relatively, we've largely left in the shadows these other kind of aspects. So the really good appreciation of the patient experience, social processes, cultural processes, these things that aren't strictly kind of quantitative, more qualitative and mixed methods in nature when we're talking about research, or more kind of qualitative in nature, focused on narratives when we're talking about clinical practice. So there are many other pain theories out there. What I just wanted to present here as an intro was some of the kind of general trends that we see in medicine and pain research. So of course, in parallel, there's many other approaches that have been going on. So just as a little bit of a recap, so we had Descartes in the 17th century, very kind of linear and kind of mechanistic approach to pain. So the signal goes directly up to the brain, the person experiences pain. Then we had the gate control, 1965, saying, wait a minute, it's not just this simple linear path. There's also the signals can get modulated at the spinal cord, and the brain isn't passive, it has this active role as well. Then in the 90s, 2000s, this kind of decade of the brain where we looked to the brain to explain all different types of things. And that leads us more towards the image on the bottom, where people are saying, well, wait a minute, like maybe we just need to focus on all of it. So tissue injury or certain types of pathology if relevant, the spinal cord, the brain, but also that broader kind of social context, social interaction, the environment, how that can shape the experience of pain. So that really all leads us up to the kind of the biopsychosocial model. So proposed kind of more formally in 1977 by George Engel. And ultimately he argued just that, is that we shouldn't focus just only on pathology or only on biochemical processes. We also need to consider psychological processes, these social processes. So although Engel proposed this in 1977, only more recently are a lot of professions are starting to kind of actually adopt this. So I think of examples like the physiotherapy profession. Just over the last several years, people are really starting, I think, to kind of seriously consider the biopsychosocial model. And over the years, people have applied it to pain. So saying, well, it's not just a general framework. We can now just map that onto pain and appreciate how it's not just about biochemical processes. We need to also appreciate social factors and psychological factors as well. So people started labeling this kind of the biopsychosocial approach or biopsychosocial model of pain. So now hitting on the title of the talk here. So is the biopsychosocial model adequate? So I think when we really start to take a deep look at it, what are the foundations of it? It really does lack a strong theoretical foundation, a huge advancement. But when we look at some of the details, there may be some features missing here. So for example, so the landmark paper in 1977, so there was this kind of like short and kind of vague paragraph that general systems theory is the theoretical foundation for the biopsychosocial model. The later paper in 1980 expanded on this a little bit, but still quite vague, proposed the idea that there was this vertical kind of hierarchy depicted on the right side there, and that information flowed somehow kind of across these different systems. And unfortunately, I think contrary to what George Engel was hoping, was a lot of people kind of view this vertical hierarchy in maybe ways that were unintended. So taking that person, taking that experience and simply reducing them down to their central nervous system or cells or molecules. In terms of application to pain, so huge advancement. Once again, I'm not downplaying the contributions of the biopsychosocial model. So it helped us actually appreciate the variety of factors that may contribute to pain. But we also have to ask ourselves, does the biopsychosocial model as it's commonly laid out, does it really help us understand pain, which is now widely, there's kind of wide consensus that it's a subjective experience. So does it really get us closer to maybe understanding that subjective experience? So what I'm going to do now, I'm going to pass it over to Sabrina, and then I'll come back at the very end and wrap it up with a couple slides.
Yeah, thanks a lot. So I'm going to share my screen. I hope that everyone can see this now. So I hope everyone can hear me, everyone can see me. Okay. So yeah, thanks a lot for this great chance to talk here. And I'm directly connecting now to what Peter just has said, namely that, of course, the biopsychosocial model has been a great, or really contributed to a better understanding of health and care. But we think that the biopsychosocial model has still been often applied in what we consider a misguided manner. This has to do with the fact that it has been biomedicalized, fragmented, and used in linear ways. What do we exactly mean by that? So with the biomedicalization, we mean that there's only some form of holistic coding, so that it's going to be said, yes, we need biological aspect, we need psychological aspect, we need sociological aspect, and take all them into account. But in practice, then there's a search for a certain kind of bodily or brain cause for the pain experience that can become our target of intervention. And this means, so to say, a de-emphasization of the psychological and also the social aspects instead of taking them as equally relevant. And also in part, it means that when we look, for example, at the psychological or the social domain, just some aspects are taken into account. Let's say certain kind of thought patterns or certain kind of relationships, say with families, instead of like taking into account this whole range of different kind of emotions and self-narratives and different kind of beliefs and expectations that play an important role, also to take into account which role broader socioeconomic processes, institutional aspects, or for example, also stigmatization can play. The second aspect of fragmentation relates to that when we consider the processes of all the different domains, that they are still studied independently. So think about, again, this nice picture of the elephant where everyone is zooming in and just looking at one particular kind of aspect. And this is in a certain way important. I mean, we want to have certain kind of research question where we want to know what's happening in the brain, what happens in certain social aspects, and that we need certain methods, and we zoom in and investigate that. But quite often, to understand chronification, it's not just important to know which factors are involved, but to see how they relate to each other, how they interact, how they shape each other. So more to understand how the relation and the dynamics are in that. And therefore, we, so to say, often need to maybe have a different approach where we see which inhibitory and facilitatory relations we have between the different kinds of domains. And so to say, see the perspective of people that work on the other aspects. And finally, we think that there's still often a linear or mechanical use. So just think about, again, about this picture of the clock where you have the different gears, where one gear is doing something, then another gear is doing something, where we have this domino-like effects. But what we thereby miss is to see that there might be feedback loops, that the different processes that are involved in the chronification don't stay the same as like stiff building blocks that just sum up, but it's more that there's certain kind of dynamics that the different processes that are involved shape each other, and that thereby we have, for instance, certain kind of visual circles that might occur, and that we need to take this into account. We therefore think that it's important to face the so-called integration problem. That's a term we take from Sonika Dehaan. And this just means that we have to understand how the processes of the different domains that have been introduced in the biopsychosocial model, how they actually relate to each other. And this, of course, includes also how we understand or how we conceptualize chronic pain. So does this mean that then chronic pain is a brain disorder? Is it something social? Is it something psychological? What is chronic pain when we actually say we need to take it seriously, that processes of all three domains are involved, and if we start to understand how they relate? And I mean, so far we have just said, so to say, how the biopsychosocial model has been misinterpreted in a certain way, but we also, of course, need an alternative, how else to think about this. And finally, of course, this relates to the question of how we can best treat pain. And what we try to do is to develop an enactive approach to acute and chronic pain that builds upon the biopsychosocial model, that's deeply inspired by it, but that allows us to address the integration problem. So to better understand how the different domains relate to each other, something that the biopsycho model originally has been quite vague about. And we understand enactivism here in the first place as a lens that allows us to reconsider pain from a new perspective with a clinical focus. So we rather think of it as a useful methodological or conceptual toolbox than a dogmatic approach that's, so to say, not flexible. So what is enactivism? That's a very difficult and tricky question, because enactivism is more of a family of different approaches that surround certain kinds of core topics, one might say, but I doubt that there's like a fixed set of assumptions that all enactivists would equally agree on or equally consider central. So when we say here, we talk about enactivism, we talk about our version of enactivism that we have developed with respect to pain. So there's a huge variety of different theories of enactivism. You just see a few examples here on the slide. And there are different nuances, there are ongoing debates, so please don't take this as like this is an activism per se, but we hope to make clear what kind of basic ideas an activism brings to the foreground that can be useful in their application to pain. And we think that three aspects are particularly relevant. This is that an activism highlights the lived experience of people and their transformative potential, that it highlights a person's active engagement with their world and their perceived possibilities to act, and that it focuses on the dynamic bidirectional relation between people and the environment that's mediated by the body. And I will say a bit more about these three aspects in the following. So start with the phenomenological aspect, or the lived experience and the transformative potential. This is a combination, or this is where the enactive tradition is taking ideas from what's called phenomenology. The most important inspiration for us here is definitely Maurice Merleau-Ponty. And one of the basic ideas here is that we as humans do not perceive the world from a detached point of view, but we experience our own physical and social environment as relevant for us because we can make use of it in a certain manner. So we are not neutral with respect to our environment, but we perceive it as being relevant to us, and because we can do something with it. Just think about a box. I might perceive a certain box, not, so to say, primarily that it has a certain shape, a certain color, a certain weight, but I perceive it as I can do something with it. And how I perceive it might depend on who I am and what kind of stance I have towards the world, which structures my thoughts, emotions, feelings, and intentions. So for example, if I see a box and I'm tired after a long working day, I might perceive it as something that's relevant for me as I can sit on it. If I want to go to another kind of meeting, I might just entirely ignore it because it's not of relevance for me right now. As an athlete, if I have a box along my way, I might experience it as something to jump over. And I don't know, as an electrician, I might perceive it as something to stand on to repair something on the ceiling. The interesting thing is that we do not only perceive the world from a certain stance, but also ourselves, what we can do and who we are, so to say, and also our body. So we perceive our body as being something we can do something with, so a medium through which we can interact with the world, but maybe also as an obstacle in doing what we actually want to do. Now, the second aspect where enactivism, or the enactivism we try to develop, relates to ecological psychology is that enactivism highlights the intimate link between pain and action. And one idea that our work relies on is affordances. So affordances are action possibilities available to a certain organism. Without going much into detail, what's important for us is that when we consider affordances, we can thereby consider the unique action possibilities that a person experiences as available in a certain moment of time. So we experience our environment as full of things we can do with this. There's like a glass of water that I can drink from. There might be this chair I can sit on. There's this couch that I might lie on, the TV that I might use to watch things. So our world is like there's a lot of things that are available to us in our environment. And given who I am again and in which condition I am, I might perceive these things differently. So some things might appear more relevant. Some things might appear attractive. Other might appear that I should better avoid it. Some things might appear meaningful to me in a deeper sense with respect to who I am. Some things might appear important to the here and now, and others are more for future plans that I might have. And the interesting thing, or why we like affordances to work with this kind of concept, is that it's always about an interactive relation. So it's about the environment and the person. So think about our box again. Whether I perceive the box as something to jump over might depend on a lot of different factors. It might depend on how tall the box is. It might depend on how tall I am. It might depend on whether I feel exhausted right now. It might depend on whether I have certain concerns or expectations. So maybe I'm afraid of that someone else might see how I jump over it and fail to actually do and fall down. It might depend on how I've grown up, whether in my environment it just has never been like an adequate thing to jump over boxes in the first place. And of course, and this is already, so to say, something I wanted to say more about later, is like pain experience might also substantially change how we experience the world and what action possibilities has for us. So what we are interested in is particularly two kinds of things. The first is more of a static question where we compare acute and chronic pain and ask like, how do they shape our lived experience? So how we experience our environment and ourselves and our body. And so to say, the different kind of action possibilities that are available to us. And this relates to the two things I've just introduced. And then there's this dynamic question where we ask like, how do the physiological, phenomenal, existential, psychological, and sociocultural processes interact in the transition to chronicity? And that's where we say, here we need to look at the bidirectional relation between the subject with their body, with their particular brains, with their particular concerns and needs and narratives, and the environment. And this is what we're going to address a little bit more. So what would an enactive account tell us about acute pain? So one idea is that people constantly relate and interact to their environment, aiming for an optimal grip. So the entire life is a process of attunement, disattunement, and reattunement. So just think about, we try to find the perfect distance between us and the TV in the evening to have the perfect visual experience of watching a certain movie. So here we have, so to say, an attunement. We might go forward, we might say, oh, that's not the perfect distance, go back a little bit more and try to find that. We can also think about this as a process in like a conversation we have someone, where we try to find the right speed of like answering people without interrupting and like waiting before someone else is saying something. We can also understand this as a form of a process of attunement, disattunement, and reattunement. Now, the interesting thing is that in a lot of these different cases, the idea is normally that the body is the medium through which we interact with the world that allows us to do all these different forms of attunement. And the body thereby is not itself on the focus. So it might structure our experience in the background, but the body is, so to say, transparent. It doesn't come into the focus itself. We focus on other kind of things that our body allows us to do. But interestingly, in pain, this changes. The body itself comes into focus. The body demands for attention, so to say. And this changes not only our experience of the body, but also our experience of the world. So, for example, when we experience an acute pain, say we have a pain in our hand after touching a hot plate, we might experience the opportunity to put our hand under cold water as something very attractive, while experience the possibility to touch our hand as something to be definitely avoided. So acute pain seems to fulfill a biological function in coloring our experience in a certain way, and as, so to say, let us see our field or affordances in a certain way, our action possibilities. And the interesting thing is that in acute pain, the people are very actively engaged with the environment. So they are activated to do something. They are normally like searching for different opportunities to return to an optimal grip, sometimes through try and error. So for a short amount of time, they're really focused on the here now. Certain action possibilities appear very attractive, and others might be just ignored. But normally, after a while, we return, so to say, to our default stand. And by performing certain kind of actions, we come back to our optimal grip, which means also to protect and maintain our bodily integrity. In this sense, one might say that acute pain changes our stance towards the world in a certain way, but just for normally a short moment of time. We might think about this as a rubber band that's for a short amount of time stretched into a certain direction and then slowly goes back in. The interesting thing is that in chronic pain, this doesn't seem the case. It's more as if the rubber band is stretched for so long that it cannot return back into default. So chronic pain substantially transforms the manner in which people construe their environment and respond in relation to it. Chronic pain affects the interactive relation between person and world in a profound manner, permeating all aspects of a person's life. So the pain here becomes a deep-rooted part of who the person perceives themselves to be and the future they see for themselves. Now we use this phenomenal triangle to indicate which manner the lived experience of a person in pain is transformed through the chronic or the persistence pain. So on the one hand, we might look at how the experience of the world changed. So the world here is experienced more often as a hostile place, signaling potential for re-injury, increased pain, or embarrassment. So when acute pain is activating the person, this is something that makes the person more passive. We become actually no less engaged with our environment. We experience our environment as not being full of things we can make use of. The box, for example, is no longer experienced as something we can sit on, as something we can stand on, because our body is, so to say, no longer able to allow us to interact in this way with the box. So we can think of that the world closes itself to the person, which actually come more and more from a distant or disengaged view on the world. And as already indicated, this also influences our self-experience and the experience of our body. So chronic pain patients, we say, often lose trust in their body. They are experienced as broken, as weak or old. Chronic pain patients often also experience themselves more useless, often especially when they can no longer engage in meaningful activities in families, in friendships, but also in religious or other kind of social communities. And affective people hereby often feel that their actions are determined by the pain. So this is like a feeling of passivity that comes with a reduced feeling of agency and authenticity, just as this different experience of the world comes with feelings of alienation. And what we see, so to say, in the overall style of self-world engagement, that chronic pain patients especially lose the ability to flexibly attune and relate to the environment. So they are biased to see the world in a very specific kind of way, so that they no longer go into this process of disattunement, reattunement, attunement, and so on, but are really, so to say, stiff in the way in which they are able to still engage with the world. And thereby, this is often not just seen for the present, but it's something that's projected into the future, so that there's no possibility for change is seen on, so no change on the horizon, so to say. So what does this mean for our understanding of chronic pain? So we understand chronic pain as a disruption of the interactive relation between a person and the environment that permeates all domains and many different aspects of life, including the world experience, the possibility of how to interact with the world, the self-experience, and the experience of the body. We consider chronic pain here as a disruption because it prevents the person from the optimal attunement to the environment, while there's no sharp point of distinction between an altering and a permeating stance. So we know that there's like no clear distinction normally in this temporal scale that goes from acute to chronic pain. We often try to highlight is that time is not really the relevant factor. Chronic pain is not just acute pain that has failed to stop, because there are also some chronic pain patients who might not suffer in the same way from chronic pain, but might actually manage to live with it quite well, though these cases might be more rare. And there might be some acute pain patients who actually suffer from their experience in a similar way as chronic pain patient. What is more important is whether the kind of experience is here really permeating all these aspects of life and changing the general, so to say, background that structures how we relate to the world, how we think about things, how we feel about things. And what is quite important for us is that in all of this, we are always talking about a relation between the person and the environment. So when we say that a person is insufficiently attuned, this is not about putting any blame on the person. It's always about an interactive relation. And this relation always has many different factors that come into play. And these are bodily aspects, these are psychological aspects, and these are social aspects. And I will say a little bit about more now when it comes to the process of chronification. So when thinking about the chronification and our three domains that we had, so the biological, physiological aspect, the psychological, phenomenal existential aspects, and the social cultural aspects, we think that none of these domains are more fundamental and none of their methods is to be prioritized for principal reasons. So of course, if we want to know what's happening in the brain in the process of chronification, we need neuroimaging data. We need to zoom in there. If we want to know how do certain kind of psychological aspects work, we need tools to do exactly that. But none of them has, so to say, priority. None of them is more important. And we think that the different domains cannot be simply reduced to each other as perfectly mapping levels, so that there is not this perfect veridical hierarchy where we can say, oh yeah, we can reduce the social aspects to the psychological aspects to the biological aspects, for example. I think these domains are rather overlapping in many ways. They are cross-cutting. And of course, we can say some of these things are more global. A few of them things are more local. So when we, for instance, zoom into the brain, this is a more local thing than when we consider, for instance, socioeconomic processes. And we can also look at them as being more or less temporally extended. So sometimes we're interested what happens in a few minutes, and sometimes we're interested like what's happening in over a couple of months, for example. But it's most important to see these processes. They overlap in many different ways and they dynamically interact and along feedback loops. So this means we cannot work with this picture of the clock where like one gear is changing the other gear is changing the other gear, but we more have to think about this as baking a cake. This is an example that we take, or an illustration that we take from Sanneke de Haan's work again, where she's saying we should more think about, so for example, the social cultural aspects as the flour and the phenomenal existential aspects as the eggs and the physiological aspects as the sugar. And what's happening in the chronification of pain is all of these things come together. They react with each other. They change each other. We cannot look at the patient and nicely cut out all these different things and just take out, so to say, the broken gear. That's not possible because all these things are intertwined. And of course, these things are to a certain way distinct, and we can use different methods to investigate them, but they are not separate, and we don't have, so to say, this nice picture of gears grabbing into each other. Though this would be quite nice, of course, it would make things easier, but the point is that chronification of pain is not easy. It's a very complex and dynamic process. So maybe the best we can get is pictures like that, where we have a lot of different aspects that interact with each other, that facilitate each other, that inhibit each other along time. And this is really, I think, although this picture is something from our paper, it's already a strong oversimplification, of course, schematic. And in fact, this picture might be different for every single patient. So taking all this, what I've just said together, I think what we try to argue for is that we need to integrate insights from all the different domains, consider the bidirectional dynamic interaction between the process of the domain, and thereby put the person that's in pain with their physiological aspects, with their psychological aspects, into the focus, into there, and see them in the environment. So to a certain degree, that means to zoom out. So of course, we have aspects in many different fields, but to fully understand what's happening in chronification, we need at least sometimes take the time to zoom out to see how these different things relate to each other, what the perspective of different people are on that, and to see that we're talking here about the patient as a person with all these different aspects that's always located and embedded in a certain environment. This, of course, comes with the fact that we need to embrace complexity and dynamics, and it also needs to accept uncertainties. When we would have this nice little gear picture, then we would say, if we take out this gear and replace it, then with like 100% certainty, we can say this treatment is going to be effective. If we take the cake picture, so to say, and accept complexity and dynamics, we no longer will have strict regularities that give us this nice relation between cause and effect. And of course, if we take this seriously, this should motivate interaction between fields, experts of different areas, and maybe also between philosophers and empirical scientists, as we've done so far. And yeah, at this point, I will, so to say, give back the presentation to Peter and just go to the next slide.
Awesome. Yeah, so I'll wrap it up here. So what are some of the clinical implications? So I think, as Sabrina nicely highlighted, is that there's kind of these many routes to change. And within typical kind of enactive frameworks, we don't a priori exclude or kind of advocate for any particular treatment. Treatment effects can be quite different than what's expected. And I think most of you who are clinicians and patients as well will have experienced that. You expect a certain outcome with a certain treatment, and things often go in very different, unusual ways than we expected. And I think it really makes sense when we think about all these different factors that are involved, dynamically interacting. Within that, we also have to appreciate that the initiating factors of pain may not be the same as maintaining factors. So in situations like the non-specific pain example that I gave, it doesn't always make sense to try to look back and try to find this kind of root cause of pain. Within kind of enactive frameworks, there's an appreciation that multifactorial and multidisciplinary approaches seem to be the most promising, probably because we're intervening at kind of multiple different points. And we need to consider the unique individual, the unique patient experience, while also searching for kind of similarities in the particular condition that they have. So this is obviously where research comes into play. And relatedly, we have to navigate uncertainties and probabilities in clinical practice, which I think is a lot easier said than done. Sabrina brought up Seneca Decon, and I think we resonate with a lot of her work too, in that, like, we still obviously need to take a very evidence-based approach. We still need to appreciate and use the best available research. We need to use clinician judgment, but within that kind of enactive framework, the phenomenological components that Sabrina nicely outlined, we have to have a serious consideration of the patient's context, their experiences, and their preferences. So within an enactive framework, essentially what we're getting at is we shouldn't be splitting a person up. So I talked about Descartes splitting things into kind of body and mind, or biological and psychological. I think it's pretty kind of common sense that we're working with full people, and that full person's always in a changing environment or changing context. And there's clinical relevance here. So you as a kind of clinician, I know there's many clinicians here, you're part of that environment, that changing context. And things like even as simple as our words that we use, the diagnostic labels that we assign to people, that can shape the context and that can shape the experience that the individual has. So especially more recently, there's been qualitative research, including some of the work that I've been involved with, exploring like what are the words that clinicians use. So what are the, oh, I think it's going a little wild here. Here we go. Sorry, something was just popping up on my screen there. Sorry about that. Update of Adobe, and now's not the time. So what we're seeing a lot of times with the qualitative research is patients often being told that they're doing everything wrong. They're continuing to get back pain. They're told that they're 30 years old, but they have the spine of an 80-year-old. They're told how kind of weak they are, and that can have quite serious implications. We're told often to kind of protect, if we're going with the example of back pain, we're told to protect our back, to keep it neutral, yet we're also often told to do your daily activities, go to work. So patients are often getting these kind of conflicting advice, and no wonder they're confused. So a lot of these approaches, unfortunately, they're promoting fear, a sense of fragility, and avoidance. So Sabrina talked a lot about this kind of idea of affordances. So what does that actually mean clinically? So what I've been interested in is like, how can we actually expand affordances or kind of open up these possibilities for action? So this is just one example of maybe a potential clinical implication of this kind of an affordance and active based approach. So I think when we think in terms of expanding or opening up affordances, we're forced in a sense, we can zoom in obviously on the different factors that Sabrina outlined, but we're also forced to zoom out and look at both the patient and the environment and the interaction between the two. And obviously, as I mentioned before, that environment includes you as the clinician as well as others. So within this kind of a framework, we have to truly listen to patients and understand their concerns and perspectives. If we're talking about this kind of so-called non-specific back pain, oftentimes people will want to do certain activities, but they're avoiding them over a long period of time due to worry or worry that they're going to injure themselves or cause kind of permanent pain. And I think rightly so. People are often given those messages, as I noted in the previous slide, that their back is weak, they're unstable, they're fragile. So no wonder people are feeling that way over this kind of long period of time. And in many ways, this type of language and wording may actually be closing off affordances. And it also doesn't align with our current research, current evidence. So we know that the spine is typically strong and stable. It can just be quite sensitive. So with an affordance-based approach to therapy, I think we have to be very kind of careful with our words and how they can shape how people perceive their body and their environment. So in the picture here, saying things like simple stuff, kind of goofy, but motion is lotion. It's good for the joints. It's good for the muscles. You can be sore, but safe. Those types of things may actually start to open up affordances. And I think in a really important point too, consistent with this kind of enactive approach focused on action, we can use those action-based strategies. So things like experiential learning to help a person actually work towards their meaningful goals. So with this approach, we're aiming to kind of open up action possibilities rather than shut them down unless there's really good reason to do so. And I think this approach, it does align with what a lot of people are already doing. And I think it can be, a lot of you might say, well, this is just a natural thing. This is quite trivial. I think professions like occupational therapy, they've been doing this type of stuff for quite a long time. But we also have to appreciate that much of pain care has been really kind of focused in on just the individual. So focused in on maybe even a part of an individual, trying to fix them, rather than zooming out and looking at how the person may kind of better attune with their environment and work towards goals that they've identified personally as being meaningful. And I think when we look at that kind of the literature on benign back pain or so-called non-specific back pain, we're still seeing like clinicians that are saying that they're taking this kind of like evidence-based biopsychosocial approach, yet they're kind of unintentionally still blaming patients, really focusing, zooming in on different parts of that person, rather than also considering zooming out as well. We go into clinics, we're still seeing no CBIC kind of posters on the wall endorsing this kind of message of fragility. So I think there's a lot more that we can do to really try to maybe open up these affordances rather than close them off. And I think just the last couple words here is like, I've been guilty of this myself too. So in my clinical practice in the past, I do research now, but I used to think I was doing a biopsychosocial approach, but I was doing so much zooming in and unintentionally promoting fragility and even passive reliance on care. And I'm not saying that passive care is no good. We can still zoom in, we can do manual therapies, provide drugs or surgery if needed, if it's indicated. But at the same time, we also have to zoom out and look at that interaction with the environment and wonder if these treatments are actually helping that person kind of better attune, as Sabrina mentioned. So last kind of slide here, lots of repetition to get this across. So the enactive framework really rejects this kind of oversimplified picture of pain and motivates kind of this more kind of comprehensive approach where we're appreciating the contributions of all these different disciplines and the things that they investigate. We're kind of not saying that we have this kind of fully fleshed solution. This is still this initial work. This is 2 papers, but we think that it can start to potentially address some of those challenges that we flagged, the issues with the biopsychosocial model. And once again, I think a lot of this will be kind of familiar to a lot of you, the clinicians. This enactive framework, affordance framework aligns with this kind of intuitive functional approach that many clinicians take. I think of occupational therapists, but it does also have this kind of strong theoretical foundation, this underlying theory, this stuff going back over a century that we can really draw from. So it offers a framework to bring things together. So last kind of point, we need to accept complexity and uncertainty instead of oversimplifying certain aspects. So how we do that in clinical practice, a lot easier said than done, but I think we need to think more about that kind of team-based approach and how we can work with kind of patients, not simply just on them. And with that, I see there's lots of questions, so we'll stop sharing slides here and get into it. Thank you so much.
Thank you, Peter and Sabrina. I really appreciate the talk. Okay, so just a reminder, if you do have a question, throw it into the Q&A. Sorry, my screen is touched up. Okay, and I will take them in order that they appear. So, the first question from Morton, are we experiencing the world through our body or our physical boundaries? So are we experiencing the world through our body, or are we experiencing it through our physical boundaries? For example, stick as a tool included, but our spleen is not. Is the question clear, or does Morton need to add a little more to that?
I think it's clear. Sabrina, do you want to tackle this one?
I think that's a very good question. I think that's a question really going into the phenomenology tradition in there. So I would say that, of course, the physical body itself, so to say, not the lived body, but the physical body, of course, has a relation to how we experience the world. But what is often more important, and this is already indicated with this tool example, that of course, certain kind of things can become a part of how we experience the world. And of course, we especially see that there are certain kind of conditions where people experience the world and also their own body in a way that has almost nothing to do with their, so to say, their physical body. So how they experience that. And we see this, for instance, in eating disorders. It's like a typical example where we have this difference between these kind of things. And in a certain way, it's in some cases of chronic pain, one might say, like, but this physically, this person is able to do it. But what is for us, so to say, what we try to highlight is, but if the person doesn't experience that as a possibility for them to do these kinds of things, this is what has to be worked on. And so to say, this has to be addressed. And there are many different factors that come into play. It might determine whether the person experiences something as a possibility for them. And we also know that a lot of these things work as self-fulfilling prophecy. So that in a certain way, expecting to fail will make the person fail, because they focus so much on the body as the focus, so to say, of the intention instead of the medium through which they can interact with the world. And part of training can then be, and treatment can be, to make the person focus more on the environment and what they want to do, and to have positive expectations about that. And that this is often more important than, so to say, in which condition the body actually is, if this is, so to say, where the question was going.
Thank you. Okay, sorry, we have a lot of questions, which is excellent. So I'm just gonna, and we don't have a ton of time, so I am just gonna, and Morton's saying thank you. Okay, so I'm just gonna pick a few questions, and apologies if I don't get to yours. So how is an affordances approach different from motivational interviewing, say? You talked a little bit about, you know, that's, for example, motivational interviewing is a tool of occupational therapy. So how is what you're talking about, how is it different from some of those approaches that do, I guess, consider the integrated kind of whole person?
Maybe I'll have a brief comment, and then Sabrina, if you want to add on to that. So I would see it like, so affordances are more like a theory for perception, or motivational interviewing could be a strategy or a technique that could then shape a person's perception. So motivational interviewing itself is not a theory for perception. It's more kind of like a tool. So I think they go nicely hand in hand. And so I like, without saying kind of this is motivational interviewing, a lot of what I was talking about had kind of elements of that. And that's usually something that's a part of my teaching. And I think they go together. But affordances comes with this kind of whole kind of lineage, and it's more focused on perception and how we perceive our bodies and our world, rather than like a treatment strategy in itself, if that makes sense.
Brilliant, that's helpful. Okay, Judy's comment is, it's wonderful that you're proposing a model to help instill a deeper understanding and application of the interaction between elements of the person with pain. The social communication model proposed by Ken Craig also provides an inclusive framework for organizing and considering these facets and their relationships. So how do you compare your framework to his?
Yeah, it's been a while since I've looked at that. So in the 2019 paper, I do cite the social communication framework by Kenneth Craig. And I think if we're talking about like moving towards a biopsychosocial framework, that's definitely in that realm. I think there's certain elements though around perception specifically that this enactive framework really brings to the table. But if I recall correctly, I don't think there's anything really unusual that kind of contradict each other in those models, but they would be more kind of complementary. They have kind of different pieces that they could bring to the table. So merging them together, or kind of having that communication framework under this broad umbrella of enactivism could be helpful. Because this enactive approach, it is just broad strokes. It's like big picture framework, which is maybe a benefit, but also an issue, because it's like you want to do everything, which, yeah, lofty goals.
Well, I think it's interesting. Like a lot of these questions are just they're trying to situate this approach and sort of differentiate it from other models that people are kind of already using that aren't necessarily linear, right? Like they are kind of considering like the whole person, and so that's what I'm kind of seeing is just trying to kind of reconcile this enactive approach with what folks might already be doing, which is potentially an integrated sort of approach, if that makes any sense.
Love it.
It's well, very, very interesting. Okay, I think we can have one more question. Are you seeing any that there's so many good ones. Any you want to answer here? Maybe there's, okay, how about this one? So Julian's asking, can you say a little more about how the language clinicians use can either close or open the person to affordances? Why do you think openness to affordances is important for the person's treatment?
Yeah, that gets pretty complex. Sabrina, do you want to touch on that?
Yeah,
Or?
I can try. So it's not that language per se is important. It's more of that language in clinical interaction. So that language is an important part of how we socially interact with others and what we hear, which then also influence how people on what they focus. So just a simple example could be to make a person say, do this or that with your hand, or do this or that with the cup, where you use your hand, but your attention is on the cup instead of your hand doing something with it. That as a very basic and stereotypical paradigmatic example, that here in how the question is phrased, or like the introduction is phrased, could change on what the person is focusing on. And this could change, for example, how the person is performing and how they experience what they are actually doing. And I think with the language aspect, this is like, I think Peter is more experienced than that and more an expert. Just think it's just like language is just one tool, so to say, in this entire thing. I don't think that language is such central, but as we are social beings that interact through that, and a lot of what the interaction between clinical practitioners and the person is happening on that, and can shape a lot of their expectations that they have, the view that they have on themselves, and they're seeing that like use certain kind of words like weak or broken can really shape the experience of the person, and the instructions can really shape how a person's performing. Yeah, I don't know, Peter, do you want to add something to that?
Love it. I think I'm good. So I'm scrolling through. I'm like, oh, these are so many awesome questions. I'm glad people are engaged. But yeah, send us an email. Like reach out to us, or through Twitter. We're on there. Like so. At least maybe I can speak for you, Sabrina. But I'm happy to receive any messages or questions. So you can find me online.
I think that would be really helpful, Peter. And sorry, Sabrina, were you going to add something?
I was just saying, yes, just write us on, like, we're both on Twitter, and that's an easy way to directly communicate with both of us. We're happy, like, definitely have to like maybe get the questions and like have a screenshot of the Q&A, because this is really exciting. Thanks a lot for all these questions and this interest and engagement.
Yeah, there's some very good questions here. I'm sorry I didn't get to them all. I do think we have to wrap it up, but thanks for taking them on Twitter, or providing an outlet for further discussion, because I think there's definitely a lot of interest in learning more and continuing this conversation. So I just want to say thank you both so much for coming today. We really appreciate it, and it's just fascinating work.
Awesome. Thank you so much.
Thanks so much for the invitation.
You're welcome. Bye, everyone. Thanks for coming. See you next time.